My approach as a nurse is, first of all, use your 5 senses. It's not rocket science. It's looking at your patient and we start by walking out to get that person to come into clinic, and as we're going out to see them, we're having a look at seeing how are they sitting in the chair, how are they breathing while they're sitting in the chair, how are they speaking, what's their colour, and all of these things are things that as clinicians we sometimes forget. We do it instinctively, and it's not until someone says to you, hey, actually, how did you do that assessment? And by the time they've walked 20 metres to sit down in your chair in your clinic room, you've actually got a fairly good idea about what you're looking at and what some red flags you might be looking at. So this is just a very brief, go back to your 5 senses. So looking at, what are you seeing when you're looking at your patient? What are you hearing? What's their breathing like? What does it sound like? What's that cough that they had on the way down that they thought they covered up that you didn't hear? Was it moist and sticky? Was it me? I've got the end of one of those horrible viruses that are going around. What are you hearing? What's their breathing like? Are they breathing from here? Are they breathing from here? Somewhere in between. Are they, as I say to some people, so noisy that they're scaring small children and animals and themselves in the process, which adds to anxiety. I don't quite, people say to me, what about taste? Well, actually, that's one of those questions. What happens when they get an exacerbation? Do they have a funny taste in their mouth? Is that indicative of some pseudomonas that they're colonised with? These things, have they got altered sensation with their food? Is that contributing to the fact that they're tiny, skinny and cachexic? Because their senses have been overridden. What was this one, Sarah?
I can jump in.
I'm going to stand on the side here so we can see our slides at the same time.
The purpose of this slide, I guess, is to show you, as Jeff has talked about, that spirometry is really important in the diagnosis of COPD. But in looking at the impact of treatment and the progression of the disease, the correlation between the spirometry results and the main symptoms, or the things that are bothering people the most, is actually not great. So we're just going to talk through some of the measures that we use to look at exercise capacity, dyspnea and health-related quality of life. So in terms of how can we measure someone's dyspnea or their breathlessness, as Nicola's already alluded to, our observational skills are just so important. How do they manage to walk from the waiting room down to the corridor? What's their breathing pattern like? Are they breathing through their nose, through their mouth, their accessory muscle use? Looking at their breathing at rest as well as looking at their breathing when they're moving. Some of the quantifiable scales that we can use is the BORG and the MRC. There is also a component in the chronic respiratory questionnaire that can be used to get a measure of dyspnea. Should I take? Oh, you're right with that. Yeah.
So as Sarah's saying, we look in assessment. We've got your subjective component, but you've also got your objective component. And your happy marriage is when you can use all of that together to come up with a really good comprehensive picture of what that person is like, functioning on a daily basis, and then when they get unwell, and then in recovery, so that you can get them back to their baselines.
So this is the BORG scale of breathlessness. I'm not sure many of you are probably familiar with it. Really good scale for exertional dyspnea. So it's a visual analog scale from 0 to 10, with 0 being you're not aware of your breathing, you're feeling comfortable, through 10 being the most breathless you could ever be. So there are some different versions around, a 6 to 20 and a 0 to 12, which gets a little bit confusing. When we're exercising people, we say you need to be around that 3 to 4. You should be around that moderate to somewhat severe, because let's face it, we should be breathless when we're exercising. Healthy individuals get breathless when they're exercising, and so should people with COPD. Then there's the Medical Research Council scale, the MRC. This is more a measure of how much the breathlessness is having an impact in their day-to-day activities. This is from 0 to 4. Be mindful, it can be a little bit confusing. There is the modified MRC scale, which is used if you're working out someone's BORG calculation, which actually goes from 1 to 5. But this is the MRC, which goes from 0 to 4. So you start at the beginning. Do you get breathless with exercise? Yes. Okay, so do you get short of breath if you're hurrying on flat ground, or if you're walking up a slight hill? Yes, and so on and so forth, till you work out which number they are. This is very much based on walking-based activities, and I have found some people do find number 4 quite confusing in terms of they might not be too breathless to leave the house, but many of them are breathless when getting dressed. So that can be one slight problem we have with that scale.
This is quite a good scale too, because often if you're getting someone and you're walking with them and you're observing them and then you give them the MRC and they point to something and you're sort of thinking, well actually maybe their subjective assessment of their dyspnea isn't what you're looking at and what you're seeing. So.
In terms of how we assess people's exercise capacity, there's 2 main tests which we use predominantly as physiotherapists, the 6-minute walk test and the incremental shuttle walk test. I'll just describe them both briefly, just for your interest. They're both submaximal walking tests. With the 6-minute walk test, patients walk along flat ground, usually a 30-metre course, and the idea is they walk as far as they can in that 6 minutes. So the main outcome measure from that is the distance that they've walked, but you're also looking for any signs of oxygen desaturation, getting a chance to look at what their mobility is like, and what are the limiting factors to their walking, which might not actually be their breathing. With the 6-minute walk test, it's considered to be clinically significant if they can walk a further 30 metres. It used to be 54, but it's been scaled down to 30. The incremental shuttle walk test is a beep test. So that's when there's 2 cones 10 metres apart, beeps on the radio, and they get faster with time. So the patient has to walk up and back at time to the beeps. A new kid on the block is the 5 repetition sit to stand test, and this is a really simple test that we've been using for our home visits for people, but is something that could be used in a clinic room at a GP practice, and we're going to go through that shortly. Just very briefly, in terms of a comparison of the 6-minute walk test and the incremental shuttle walk test, they're both submaximal tests. The 6-minute walk test is self-paced, so it's really important that you have standardised instructions that you give to patients, because they need to push themselves as hard as they can. If they don't work hard, you're not getting a very accurate result. The incremental shuttle walk test, conversely, is externally paced by the beeps on the radio. To do a 6-minute walk test, you do need to do a practice test on the same day or the next day. And an incremental shuttle walk test actually requires 2 practice tests to get a reliable result. The 6-minute walk test ideally should be done on a 30-metre track, whereas your incremental shuttle walk test can be done over a 10-metre track, so if you haven't got quite as much room. The difficulty with the incremental shuttle walk test, because it is only 10 metres, if you have a walking frame or there's balance problems, you're doing lots of turning, it can be quite difficult for patients. So the 5 repetition sit to stand test has been shown to be a reliable measure of exercise capacity, and it can be responsive to a pulmonary rehab intervention. So it correlates well with exercise capacity. Obviously there's a component involved in lower limb strength, but it also correlates with health-related quality of life and dyspnea. Just to show you a little bit more, here's the method involved for the sit to stand test, and I thought we might actually have a go at this, because it's a good chance to introduce yourself to your neighbour if you haven't done so already, and then you've really got the grasp of the test to take home to your clinical practice. So what you need is to introduce yourself to the person sitting next to you, and all you need is a chair and a stopwatch, and I'm sure many of you have got iPhones that might have a timing device. So if you would like to follow the instructions.
So make sure that you don't have a rolly chair.
Oh yeah. Okay, just to let you know, if any of you took longer than a minute, then you cut it off at 1 minute. Hopefully you didn't.
So you don't keep the patient struggling to do 5, okay? And we have a number of patients who can't complete 1. And that's really cool, actually, by the end of rehab. In fact, a lady said to me on Wednesday at Howick, you know, I couldn't even get out of the chair once, and 4 weeks on I can do it many, many times. And I said, that is awesome. Really good indicator of how she's progressed with the pulmonary rehab.
So it's a nice, quick, functional test. So those are the key tests in terms of exercise tests. In terms of how we measure someone's health-related quality of life, Again, there's lots of questionnaires that are around that we can use, and I'm just going to touch very briefly on the 4 main questionnaires that are used in the pulmonary rehabilitation setting. Each of these questionnaires has challenges and benefits, so it's working out which questionnaire is best to use in your practice. So the St George Respiratory Questionnaire is one that we used for a long time at counties because we have such a large population of people with bronchiectasis, and this questionnaire is validated for COPD and bronchiectasis populations. However, it is a disease-specific questionnaire. It's sensitive and responsive following pulmonary rehab, but it is a very time-consuming questionnaire. It's very long. I haven't put the questionnaires on the slides because they're large, but I do have copies of all the questionnaires if you'd like to see them. It takes a long time for people to complete the questionnaire, but also it takes a really long time for staff to evaluate the results. And we did a small trial. You need a computer system to come up with their final score, and we did a little audit. We tested, we had 2 physios enter the results, and the discrepancy was huge, so we felt we weren't getting very accurate results. And it hasn't been translated into many of the languages that we needed. The Chronic Respiratory Questionnaire, also disease-specific, has been used widely by many of my colleagues. Again, it's valid and reliable. It is also quite time-consuming. You do need to pay to use this questionnaire, and you do need to seek permission, so that can be a limiting factor. The CCQ is perhaps the most recent questionnaire, and Jeff knows a lot more about this questionnaire. We have trialled it for use in our clinical practice. It's disease specific, it's quick, concise, it's a 1-pager, nice and easy to use, very easy to score. Its reliability and validity has been extensively tested. Currently you do need to pay and seek permission to use this questionnaire. One criticism we did have from some of our patients was there's lots of different options, and they got a little bit confused in what the difference between several and many, and also it's not translated into the languages that we need, although it is translated into many languages, not the ones that we were needing. And then there is the COPD assessment test, the CAT, which is simple and quick. The simplicity may make it an advantage or a disadvantage because there's a chance it actually may be too simple. It's free of charge. It's been translated into several languages which relate to the populations we're seeing here in New Zealand. But whether or not it's a true quality of life measure or more of an impact of the disease, and it does certainly have a ceiling effect. So there's just might be a little bit hard to read, just a figure which has evaluated many of the different questionnaires. And on here, that actually might not be in your slides, but on here you will see that the questionnaires I've talked about all get smiley faces, so they're all considered to be good enough, but certainly in this study the CCQ came out to be the best option. So there are other questionnaires that we use in our clinical practice, and one of those is the Hospital Anxiety and Depression Questionnaire. And this is a screening tool, clearly not a diagnostic tool, but a really important screening tool to get an idea of how much of an impact the anxiety and depression is having on someone. So if somebody scores greater than 8, we would certainly be alerted to that there may be an element of anxiety or depression. If they've scored greater than 11 for either anxiety or depression, then we would look at what interventions may be required. There is the BEC, another depression questionnaire, which has been used by colleagues, but not something that I have used personally. And then there's the Nijmegen questionnaire, which is a questionnaire to detect if somebody has signs of a disordered breathing pattern. So this questionnaire, if you score greater than 23, that indicates that your symptoms are suggesting that you have disordered breathing pattern. And a couple of other questionnaires that are used are knowledge-based questionnaires, and one is the Lung Information Needs questionnaire, which gives a good idea what understanding people have of their lung condition and can be really important if you are utilising self-management strategies.
We'll often send a link out to people coming to pulmonary rehab for their first clinic assessment. So when they come into clinic, they've filled out the link, and we actually have a really good picture already of what they need to know, and we can help reuse it with goal setting.
And the Bristol Knowledge Questionnaire is another questionnaire to get an idea of what people understand about their COPD. We actually use this questionnaire in our pulmonary rehab program, so we do it as one of our little education sessions because they're mainly true or false questions, and it always alarms me, the answers that people come up with in this questionnaire, but it can be a great tool to help gauge an understanding and to give you some direction in your education. So we thought we would run through 3 different case studies of some of the assessment tools and which ones we would choose and why.
Yep. So these patients are all patients actually that Penny was a lady we saw on Monday. Stephen was a man we saw a couple of weeks ago, but we've seen him for the second time around in rehab. And Elizabeth was a lady we saw a couple of weeks ago as well. So we thought we'd just pick out real life what's happening. So Penny's come into pulmonary rehab. She is referred in. That's the referral from GP. It says on it, moderate to very severe COPD, gold 2 to 4. She's had a hysterectomy for adenomyosis, obesity, adenoma, colon polyps with an adenoma removed. She's got sleep apnea and she's on CPAP. She has a recurrent endogenous depression, hyperlipidemia. She's a non-smoker, she's got asthma, and again it says never smoked tobacco. So I had a look at the referral and thought, oh, wonder if she does have COPD. So she's age 63 with a BMI of 40, as I said, non-smoker. Her OSA is mild. The AHI, apnea-hypopnea index, over 30 is severe. 10 to 20 is mild and is moderate rather. So it's sort of on the border of moderate to mild. And then normal is less than 5 events per hour. So in between that is mild, and she's got some dyslipidemia. So she comes into clinic, sits down, do her spirometry, and what have we got there? Does she have COPD? No, she doesn't have COPD. She's a never smoker, so that goes along with her history. So when we're looking at patients, we're looking at the whole patient. So a test can help confirm diagnosis or not. But you're looking at the history, and so you're wondering where on earth did all of these things get added onto her. Now she was quite a, when we look at her blood results, and again Jeff will go into this in greater detail later, but her eosinophils are, within normal range. She's not looking as though she's, oh, and that's a cumulative report, by the way. When I sit down to talk to her, her serum IgE, however, at one stage was 249, so that's quite elevated. And so that would support that she had a history of asthma. She's also got some RAS testing, so we know that she's sensitive to grasses and pollens and things. But when we're going back to our objective assessment of her, she walked from the train to clinic. Now that's a distance at Middlemore, I reckon it's a kilometre. Sarah's measured it, it's 500 metres. And in order to get from the train that she came on, she has to go up to 3 flights of stairs across, down a couple of flights of stairs, and then walk 500 metres. And we got out to her 2 minutes after she'd sat down, and she looked very, very comfortable. She described her breathlessness as an MRC of 3. So we're sort of thinking, oh yeah, well, okay. Blood pressure was just mildly elevated. Sarah will talk about her treadmill bits and that. I'll just go back to one of the things that are interesting about her is she's on no medications. And she was at great pains to talk to me about that she doesn't have asthma, that she's had a couple of presentations to hospital in the last couple of years with wheeziness, and she's responded to steroids. But she says, I don't have asthma. I've been allergy tested, and I avoid cats, and I avoid dogs, and I avoid pollens, but the privet hedge outside gets me. And she describes this complex sort of history where when I start talking to her about things in the asthma control test, nighttime awakenings, she says, oh yes, I wake up every night. But she attributes it to fussing around with her CPAP machine. So she has this real sort of mixed picture, and I think a lot of it is denial. So eventually I've suggested to her that it could be worthwhile actually trialling her on a course of a low-dose steroid. She has some really interesting fixed ideas about steroid therapy. She did that Buteyko course 30 years ago and reckons that's another thing that she uses so that she doesn't have asthma. When I asked her to talk about what asthma is, she says, oh, it's an allergic reaction, which is why I only have it like twice in, or once a year or twice a year. She doesn't believe in getting the flu vaccine, and she has this very long story about that, which I'm sure you'll hear from your patients as well. But then when I'm talking about her CPAP with her, she uses it very haphazardly, and actually she has poor sleep. So I think this woman's asthma is poorly controlled. Everything she's telling me is that she's waking up every night. She doesn't quite make herself a meal in the middle of the night, but it sounds as though it's almost that. And she's a comfort eater, which goes along with her depression, and she's a little bit, she is overweight. So we've got a lot to do in terms of goal setting and pulmonary rehab. I'm going to go back to her.
In her physiotherapy assessment, subjectively, she talked about being short of breath if she walked up hills or if she walked upstairs, but she was telling us that she attended a weekly exercise group and that she had a treadmill at home, which she used regularly, and that she was trying to walk ground walking as well and aiming for about 2 kilometres. When we looked at her breathing pattern was actually really good. She could breathe through her nose, she was breathing well from her diaphragm, she had a nice relaxed pattern, she could speak comfortably. So we took her on a 6-minute walk test. Her MRC, interestingly, was 3. When we took her on a 6-minute walk test, we didn't actually attach her results, did we? No. She walked 510 metres. To put that into perspective for you, whenever we have student physios coming through the program, we get them all to do a 6-minute walk test, and I tell them if you can get to 1 kilometre, I'll buy you a coffee, and I haven't brought any yet. But many have got to the 900 odd. 510 for someone with COPD is actually pretty good. Carol, you'd maybe agree. So that's a good distance that she could walk, and during that time her heart rate didn't actually go up very much, and her oxygen saturations remained good. She completed a hospital anxiety and depression scale. Yeah. And she did score 10 for anxiety and 10 for depression. So there were some issues that needed to be dealt with there, and certainly a component of anxiety and depression. Her CAT score was 15, so she didn't have a lot of symptoms related to her COPD. But what was going asthma. But what was going on with Penny was that she did have quite a lot of left hip pain, and she also had some stress incontinence. So although she was doing all this exercise, she was never actually pushing herself very hard. So there was certainly what sounded like she was fit and active. There was actually quite a lot of exercise intolerance because she wasn't really working at a hard enough intensity to get the benefit from it. So despite the fact that she doesn't have COPD, we enrolled her in our pulmonary rehabilitation program, and we have got her on an exercise program where we are just trying to push the intensity and work on her fitness level a little bit more to overcome some of the difficulties she's having with breathlessness. And
one of the things I really love about rehab is ours is an 8-week program. They have 16 opportunities to talk to experts in respiratory medicine. And I very much take on board, and Sarah does as well, the whole philosophy behind brief interventions. So you know, you have an issue, like my issue for her is going to be talking to her about her asthma, getting her onto some inhaled steroid, getting her to trial it to see if there's an improvement, getting her to bring a CPAP machine in so I can sort that out for her. And we're going to be talking to her about, you know, flu vaccines and stuff. But it's just like little bites, you know, a couple of minutes here, a couple of minutes there. And then by the time we finish the program, they've learnt a lot and they're a different person, because hopefully you've managed to not quite badger them, but certainly help instill some information and let them also test that information. So it's a case of getting onto the GP and seeing if we can get a prescription for some low dose, and I talked about QVAR actually, with her, and getting her to trial it during the 8 weeks that she's on the program. So we've got an end point, and we can say, okay, how are you doing from here? And then we've got a reassessment and say, this is what we see objectively, how are you finding things subjectively? Yeah.
Should we do one more for time?
Yeah, we'll do one more.
Are you tackling her BMI?
That hopefully will come alongside it, Jeff.
Because I think that's the main thing.
Yeah, absolutely. And I mean, that's some of the stuff that we've already talked to her about, her weight and... But often people, when they're depressed, and she's admitted she's a comfort eater, when you sort of, the weight has to come in from an oblique angle. When they start sleeping better, then they start feeling better about themselves. They start seeing those gains, that they don't get so breathless climbing those stairs. Then things can follow on from it. Yeah. Stephen?
Stephen.
All right. Stephen is a repeat offender. He came into rehab a couple of years ago. He's quite an interesting man. He's got a 100-pack year smoking history, and he was exposed to working in sugarcane fields in Fiji and the burn-offs that they have there, so quite a lot of exposure to noxious particles. So when he was referred by the GP in February 2013, his diagnosis was COPD, and that's what you would be expecting just simply from his smoking history and his exposure. He had had 7 non-STEMIs and had multiple angioplasties at that stage, but when he came in to see us this year, or a couple of weeks ago, he's now, the cardiac team have said no more surgical intervention. You're not at the stage now where we can look at that. He has got dermatitis. He's under the dermatology team, and in between being referred back in and coming into rehab, he had a presentation in Middlemore with syncope. Now this man has been through our disordered breathing clinic back in 2011, and his Nijmegen score was 28 out of 64. Now in clinic, when we've got a computer available, I actually like just getting the patient I just go into the Dr. Google there, pull up the Nijmegen questionnaire, which I think is on the Bradcliffe website, and sit the patient there, literally 1 minute, 2 minutes max, just get them to fill it in, and you've got your Nijmegen score all filled out, and they don't, I think it must be something about sitting in the clinician's chair at their computer that makes people not rush to, they don't sit and linger over the questionnaire. But we actually found that this time his Nijmegen was higher than it had been after he'd been treated for HVS in 2011. In 2013, he had been using Flexitide, Serotype and Ventolin very haphazardly. This time, he was using Ventolin, Spiriva and Durolin haphazardly. He was using his Serotype as it was prescribed, and he says this one every day. English very much second language, and it's something that had been commented on through his previous presentations. The rest of his meds we know he was taking, blister packed. We have a really good scheme on our computers at Middlemore where we can see most of the pharmacists in the greater area are hooked into the scheme. We can see what medications are being picked up, when they're being picked up. Saves a lot of phone calls, which is fantastic. So if you have a look at this guy's eosinophils, and I said to Jeff yesterday, this guy's got elevated eosinophils, but I'm going to toss in the fact that he is from Fiji, he's got exposure to parasites potentially, he's got dermatitis, so you can't just assume when you're looking at the eosinophils that it's only from airway inflammation, that it's only a marker of airway inflammation. But I won't say anything more about that, hey Jeff? There's his spirometry. Okay. Any comments about that? It sort of fits with the picture of what he's got. So do you want to go back?
Oh, sorry.
FEV1 of 54% predicted, FVC of 54% and a ratio of 73. So it's not doing too badly. And there's a 6-minute walk test.
So when we met Stephen, he's been suffering from a lot of dizziness. So before we actually undertook a 6-minute walk test, we did a balance test with him, which was the Taniti balance test, and he scored 22. So he's sort of moderate to low risk of falling, but he actually demonstrates a really disordered breathing pattern, which is not surprising given his 38 score on the Nijmegen questionnaire. So he's very much an apical breather. He can't speak full sentences without taking big gasps of air, lots of sighs, and I feel that there's likely to be an element in his dizziness related to his breathing pattern disorder. He was getting very short of breath. He described his MRC score as a 4, so that means he was breathless when getting dressed or too breathless to leave the house. And functionally, he was really limited. So this walking test showed that he walked 232 metres in 6 minutes, which is pretty poor, and during that 6 minutes he did need to stop twice. Now, he didn't desaturate at any time during the test. His oxygen levels stayed good, and his heart rate barely moved, so he wasn't exerting himself too hard on that test. So there's quite a few components that we need to address for this chap. We certainly need to look at his breathing pattern at rest before we can start to get him exercising, and teaching him good breathing patterns to overplay into using while he's exercising.
From a medication perspective, just talking to him about his meds, he's getting calf muscle cramps every night, disturbing his sleep, and he's on a very high dose of atorvastatin, so that's something I've flicked back to the GP to consider changing him onto rosuvastatin or something with a lower profile of side effects. When he was using Ventolin, he's taking 4 puffs at a time. Again, that's something that we immediately start off by addressing. He's taking his Spiriva in the evening and not in the morning. And often we've found that patients just changing them to taking it in the morning, immediately they'll come back and say, oh, I'm feeling so much better, you know, in terms of managing their breathlessness through the day. Stop the Duolin. In fact, I said to him, let me take that one and return it to the pharmacy when his list, and then I phoned the practice to talk about the recommendations that we were making around his medications. And as I said, he's using a Seretide 2 puffs twice a day, but with his high eosinophil count, as Jeff would say to you, he probably would need some more inhaled steroid. And that would certainly be something that we case conference with one of our SMOs every week, and so our recommendations around medication, because I'm definitely not a prescriber, are backed up by our SMO, and so that information that goes out to the GP has been stamped from that perspective. But sometimes we'll talk to the practice nurses early and just say this is a flag of what we're coming through, and that'll be followed up in our letters. The other thing is furosemide. Often it's blister packed, whereas in actual fact, if you look it up in the schedule, it says take on an empty stomach, and most people are taking it with their breakfast. And we suggest that the patient get the pharmacist to identify the furosemide and that they take it very early in the morning on an empty tummy, hop back into bed for half an hour, and then head about their day. And for some people, their control of their fluid, just that one intervention makes a world of difference. And at times they're able to reduce the amount of diuretic they take because they're taking it properly. What else do we do with him? Oh, that was it. We go into smoking history. And as I said, he's got this massive smoking history of 100 pack years. And one of the things that I've learnt working in South Auckland is I'd never assume anything. And so my question for any patient, regardless of what they look like, is, you know, what did you smoke? Not just how much did you smoke, but what did you smoke? And this man actually has never smoked tobacco. He smoked mealies rolled up in banana leaves, which was what he calls Fijian cigarettes. And there's a variety of plants that are called Samoan cigarettes, Tongan cigarettes, and so on and so forth. So it's really important not to make any assumptions. And I think, yeah, one of my case studies later will highlight that again. Yeah.